clavicular, back down here, in this position here, in the intercostal space. So I take my other hand, and I'm going to hit my finger. And I'm listening for this sound. It's hard to hear when you've got the fan going, but you listen for this sound. And it should be what they call a resonant type sound. It's air in there, so it's more of a resonant, airy type sound. Then I would move my finger over to this side, and I hit here. And I would slide my finger, you can see I'm kind of going like almost like a Z pattern. And I go over here again. And I go over here. So I did maybe somewhere between 10 and 14 points in the intercostals. And again, I went this Z pattern down, and I made sure I got out lateral, which is where the vesicular portion of the lung is, the periphery of the lung. So I want to assess that area.
Should you hear the same type of
You should hear that same kind of a note as you go through. Now, if you hear a dull sound, well, it could be on the bone, maybe. Or it could be that there's some kind of a lesion there, possibly. So you note this. You can't go by one thing. You got to say, well, maybe there's something there, maybe positive, not 100% sure. After I do my other parts of my exam, then I can see what's going on. And then maybe even sometimes you still don't know for sure. Now I need to do special testing. So I may do a chest film to see what's going on with the lungs. What's in their history. Couple that with everything. So you can't only just go by something with the defined the patient, because you got to correlate with everything that's going on with the whole picture, clinical picture. With that. All right, so I did my percussion. Now what I'm going to do is I'm going to get into my auscultation. Now the auscultation is probably the most important part of the exam. It gives you the most information. So again, this stethoscope, these ear portions should be facing towards my nose. So I would have this technically in my ear, but I'm going to talk, so I'm not going to do that. But it would be in my ears. And then, of course, I want to use right now, I want to use the diaphragm portion, which is for the high-pitched sound. So I got to make sure I turn this in the right direction, so I'm in that area. Patient is in the same position, crosses his arms, same position. And now I'm going to auscultate approximately about 10 to 14 spots. So again, I would take this and I'll put this in my ears. Before I do that, I would tell the patient, what I'm going to do is I'm going to have you, when I tell you, I want you to take a deep breath in like this. Then exhale when I tell you. So somewhere about 10 to 14 spots. And again, I went through the whole lung, to the periphery.
Does it matter if you're breathing your nose or your mouth?
You tend to breathe, I think, better out of the mouth because you can get better air going in.
What are you listening for?
Again, I was just going to say that. Now what am I listening for? You got the right question, at least you're listening. What I'm listening for is normal breath sounds. What are normal breath sounds? You have tracheal sounds, you have bronchial sounds, you have bronchovesicular, and you have vesicular sounds. So generally speaking, tracheal sounds, if you really, really truly want to hear a tracheal sound, you would really go in the midline per se, up into this area up higher, the thoracic spine. You're going to take so when you're with each other doing this, go in these certain points just to see if you could hear a difference. And again, tracheal sounds normally are pretty loud sounds, and you hear them better on expiration than during inspiration. You know, blow out, you hear them better. Bronchial sounds, if I go kind of more towards the mid-thoracic spine, if I went right in the midline, that's, you know, more right where the bronchi, the main bronchi are. And again, they're loud, you generally tend to hear them better on expiration. Bronchovesicular is now a little bit more, I guess you could say almost like mid-clavicular in the mid portion of the back. If I go on one side versus the other side, you hear those bronchovesicular, which really are pretty much equal during inspiration and expiration. You're not going to hear a whole lot of change in the pitch. And then I can come out here when I went out to the peripheries, that's vesicular sounds. And again, those sounds, you know, are better heard when you're inspiring versus expiring. So you try to key in on these when the patient breathes in and exhales and all that stuff. And you're also listening, those are the normal breath sounds. You're also listening for what they call adventitious sounds. Those are abnormal sounds. So when you're listening, again, over all these different areas, do you hear any what they call crackles or rails? They're like light sounds, they're like kind of crackly sounds. And you know, do you hear any of those sounds? Generally, those sounds usually are probably a little more better heard out in the vesicular portion of the lung, and a lot of times it can be associated with somebody who has pneumonia. You're also listening for any rhonchi or wheezes. You know, again, rhonchi and wheezes generally are more or better heard in the bronchial area. Rhonchi tend to be a little lower pitched sounds, and again, there's a multitude of things that can cause that. Certainly, if there's different what we call secretions in the large airways, that can certainly cause that. And then, like I said, the wheezes, which are a little bit much more higher pitched sounds, and wheezing, and they have that sound. Again, somebody with bronchitis, they have some kind of obstruction, they have asthma, chronic obstructive pulmonary disease, and the list can go on, but those are some of the major things that you're listening for when you're listening for those wheezes. Then, assuming, let's just say something was abnormal, right? Let's just make up something. Let's just say I was listening, he had his arms crossed, I was listening, and I was in the upper portion of the lung, and I listened here, and I heard breath sounds that sounded to be normal breath sounds. And then when I went over here, and I listened, I didn't hear the normal breath sounds like I was hearing here. So that potential, and then I went through everything else, and everything else was okay. So something's maybe going on here. So that's when there would be a clinical reason to do what they call transmitted voice sounds. Transmitted voice sounds is what you do is you tell the patient, what I want you to do is, I'm going to be listening, this is of course with my ears, this study still, and I'm going to have you say 99, 99, just keep repeating it. Okay? Repeat that, repeat that. I'm listening here, which I thought was the good side. Then I go over here and I listen on the bad side. And on the bad side, does the bad side sound like it's increasing that sound of 99? So I'm comparing the bad with the good. Here, I'm not going through the whole lung, just this from one side to the other, this was the air that I thought it was. Here, so that's called bronchophony. So you tell the patient say 99, 99, 99. Then you can also do.
Is the sound increasing because there's less space?
Yeah, there may be some kind of consolidation. Yeah, there may be some kind of consolidation in that for the increase in sound. Then I can do the same thing, but now I would tell him to say, what I want to do is I want him to go, ee, ee, ee. This will be in my ears, of course. And I listen on the good side with the bad side. That's called egophony. And again, if he has an increase in sound, it could be a consolidation, like a pneumonia or something. If there's a decrease in sound, it could be some kind of emphysema of some sort. So you want to listen to that. And then what I could also do as part of the transmitted voice sounds, again, comparing good with bad, what I want you to do is I want you to whisper. I want you to whisper. Right? Just like that. He would whisper, so you can whisper baseball, or whatever you want the person to whisper. And they would compare bad with good and the same thing. With the whisper, what they call whispered pectoroquility, if I can make out on the bad side what he's saying, it may indicate consolidation. And with the egophony, if the E sounds like again A, then it may indicate there's some kind of consolidation. So all these things tell you this, for the most part, consolidation. Okay, so we did those. And those, again, those are only for if you believe there's something abnormal. You don't typically do transmitted voice sound.
Are you listening for like wind in the tunnel besides the E and the O's?
Well, you did that before when you were
So you're supposed to hear wind, like wind going through a tunnel. That's what you're supposed to hear?
Well, yeah, again, you're hearing those normal breath sounds when you went through all those others. In the beginning, when you went through all the normal breath sounds, that's when you hear the air going in and out of that.
Oh, okay.
What they call the tunnel, or the bronchi and the vesicular portion.
So that's normal to hear that?
Yeah, you're gonna hear that. Yeah, that's what you're listening to hear. And then you're trying to key in when they inspire versus expire. Where do I hear it better? And it depends on where you're in the lung. It kind of tells you when you're gonna hear it better, in that area. So that would be your whispered pectoroquility or transmitted voice sounds. So again, on a practical exam, we may ask you to auscultate the lung. And you go ahead and auscultate, you're doing your normal breath sounds. Then we may give you a scenario and say, well, let's just say you were listening in the right lower lung and you didn't hear the normal breath sounds. Would you do anything as far as auscultation goes? And we'd be waiting for you to say, well, of course, I would do transmitted voice sounds. Okay, what are they? Would you say, cough?